Thank you again for joining us. I am joined by Dr. Ann Helmus, who is a pediatric neuropsychologist and the director of NESCA, and also Lauren Halladay, who is a pediatric neuropsychologist at NESCA as well. And they are here tonight to talk about everything neuropsychological evaluations. Anywhere from how do you get one, where do you get one, who do you get one with, and why, and what you can expect out of an evaluation. Just want to run over a couple of housekeeping items for the beginning. We're breaking up the presentation tonight. Anne will do the first part on neuropsychological evaluations and kind of the overarching view of those, and then Lauren will tackle the younger kiddos for neurodevelopmental evaluations for children under 5. And so what we're going to do is have some Q&A time in between Anne's session and Lauren's, and then at the end of Lauren's presentation. So feel free to put your questions into the Q&A. The Q&A has been enabled, and we can answer those for you along the way. And just so that you know, we are scheduled to go till 7:30, and certainly if there are any follow-up questions, I can help direct those to either Anne or Lauren after the presentations tonight. So with that, I would like to introduce Dr. Ann Helmus.
Thank you so much, Jane, and welcome everybody. We're happy to have you here. So I've been a pediatric neuropsychologist for more than 30 years. And in 30 years, I have written a lot of reports, and I've read a lot of reports, and developed a lot of opinions on what makes a great neuropsych evaluation and what makes just sort of a serviceable neuropsych evaluation. So tonight, I want to sort of explain what a neuropsych evaluation is and what to be looking for as you choose who to do this evaluation. Go ahead, Lauren. Okay, go ahead. Perfect. Okay, so one of the things I think misconceptions is that people think that neuropsychologists are just testers, that we just administer lots of tests like an IQ test and a reading test and things like that. And we score them and then we write up the results. And it is true that I see this sometimes from neuropsychologists and from psychologists. And that's not what a good neuropsychologist does. What a good neuropsychologist does is to use testing as one part of a comprehensive assessment. And so what we want to do is to be able to look at the testing data that we get and be able to interpret it in terms of what we know about the child, the observations of the child during the testing, their history, and so on. And a good example of that is, I think the next slide, Lauren. Go ahead and go one more. One more. So when we're talking about not just generating scores, this is one of the tests that we use during a neuropsych evaluation, which is called block design. And so we show the child the picture like on the top, and we give them blocks and ask them to recreate the picture that we've given to them. And as you can see on this one, it's a 3x3 matrix. So there's 9 blocks. And a lot of times kids who have attention deficit disorder will get 8 blocks correct, and then they'll sort of stop paying attention, or they'll get careless, and the 9th block will be rotated, and they'll get 0 points for that design. It's also true that we have some kids that come in, they mostly see Lauren, who pick up the blocks and just throw them at the evaluator, and they don't do anything with the blocks. And that kid also gets a 0. And these are obviously 2 really different kids that have very different diagnoses and need very different things. And yet what I see in a lot of neuropsych evaluations is that we just get a score on the block design test, but it doesn't tell us who the child is or why they got that score. So Lauren, sorry, I'm going to have you back up one slide. Yeah, so this is why I say like a neuropsych assessment is not like a COVID test. Scores don't speak for themselves. Yes, it is important to know if somebody got a 0 on the block design item, but it's really important to understand why. and to be able to analyze and integrate information from multiple sources. Lauren, if you can go back one more slide. Sorry. From now on, I'll go in order after this one. So one of the things that I often get asked about is what's the difference between a neuropsych evaluation and a school-based assessment? And this is a particularly salient question because parents have the right to have their child assessed if there's a suspected disability through the school system for free, and a neuropsychological evaluation is expensive. And so it's very understandable why parents would say, well, why can't we just do a school-based assessment? And typically what happens with the school-based assessment is that they will test in areas of suspected need. And so the areas of suspected need I've listed here could be academics, could be psychological if the child's having emotional or behavioral social problems, could be motor, speech language. And we certainly see kids where they've been tested in multiple areas here, and then the team comes together. But the purpose of this testing is not to give a profile of who the child is, what their strengths and weaknesses are, to understand who they are diagnostically. The purpose of the school-based assessment is because if they're going to determine that a child has a disability, they have to decide which of these federally determined categories the child falls into. And so basically what they're trying to tell from the testing is, does the child meet the federal government's definition of an intellectual disability, a communication disability, emotional disability, and so on? Because if the child falls into one of these categories, then they're eligible to receive services potentially through the school system. So the purpose of the testing is different. When we're doing a neuropsychological assessment, we're trying to understand who the child is, where are their strengths, where are their weaknesses, and how does that explain areas that are going well and areas that are not going as well, and what are the recommendations for that child to help them. So even though sometimes some of the same tests are used, the purpose of the evaluation and the scope of the evaluation is very different. One other thing is that school psychologists are not supposed to make diagnoses. And so what they might say is, our testing showed that this child had attentional issues, scored below average on tests of attention, and therefore we recommend that you see your doctor to determine if you have a disability such as ADHD. Whereas one of the things we would do as neuropsychologists is to determine if we thought the child had ADHD. Okay, Lauren, you can go ahead. So one of the ways I like to sort of teach about a neuropsych assessment is to start with a common sort of symptom, and we see this one all the time, which is my child can't pay attention well. And a lot of times parents will call and they'll say, I'm bringing my child in because they have ADD. And I'll say, well, how do you know they have ADD? And the parent will say, well, because they can't pay attention. And I've listed here on this slide, however many reasons there are here, 12 reasons or something, for why a child might not be able to pay attention. And ADD is only one of them. So kids that have sensory problems, if you can't see well or you can't hear well, it's very hard to pay attention in school. One thing we've been seeing particularly a lot of since the pandemic is emotional issues in kids. Kids are anxious, they're depressed, they have experienced a lot of stresses, a lot of changes in their family. Any type of emotional issue often will play out in terms of not being able to pay attention. Intellectual giftedness, kids who are, at the top 0.1% of the IQ distribution often find sitting in class that they feel like it goes too slow, or they already know what's being taught, or their academic skills are already so far above their classmates that it's hard for them to focus on the lesson being given, which is understandable. On the other end of the spectrum, kids whose cognitive ability is much lower than their peers may feel that the classroom is going too fast and they can't keep up, and so they'll space out. Kids who have motor issues like postural instability, they can't sit still in a chair, will find it very hard to pay attention because they're spending all their time kind of squirming around and trying to get comfortable in their chair, and so on and so forth. I think you can see how each of these following ones could play out so that they would impact a child's ability to pay attention. So one of the things that I love about being a neuropsychologist is that it's sort of like detective work. So the parent comes in and says, the student can't pay attention. And we can generate all kinds of reasons why somebody might not be able to pay attention. And then the job is, well, how do we sort out these hypotheses? How do we figure out what's going on for this particular child? And Lauren, if you want to go to the next slide. So when we're trying to answer that question, in this case, which of those 12 things could explain why this child is having trouble paying attention? We rely on 3 sources of information. We look at the child's history, their developmental history, medical history, educational history, family history. We rely very heavily on observations. So I gave you an example of that in the block design task. What are we observing? Is the child making a careless error, or is he throwing the blocks? You know, how do their problem solving skills look? How are their social skills? How do they behave during the evaluation? Can they regulate their behavior? Can they regulate their emotions? And then finally, testing. And so we are interested in the testing scores. For example, if we wanted to determine if this child had intellectual giftedness as one of the bases of their inability to pay attention, IQ scores that are above 135 or 140 would, probably indicate that this child is intellectually gifted. Similarly, for low cognitive ability, a lower score would suggest that maybe they can't keep up with their peers. And then also the process of how they got those scores, which is what I was describing in block design. So a good neuropsychological assessment will take all of the information gained from all of these areas, which ends up often being a tremendous amount of information, and try and analyze it and integrate it and synthesize it to determine what's going on with the child. So there is not a test for ADD. There's not a test for reading disability. There's not a test for autism. It's a much more sort of complex and nuanced process. Go ahead. So this was, I just want to show how this works in action. So a family came to me because they had their daughter evaluated by another neuropsychologist, and the neuropsychologist had diagnosed their daughter with dyslexia. And dyslexia is a neurologically based disability that makes it very hard for kids to learn how to read with standardized instruction. And so looking at these sources of information, what I saw is that the neuropsychologist who tested her found that she had an above average IQ, but below average scores on tests of reading and spelling. And so that neuropsychologist focused on that and said, if the child is really smart and their reading skills are poor, they must have dyslexia. They must have a reading disability. In their report, they gave some of these observations. They said that the teacher reported grade level reading skills, but said that the skills were somewhat variable. So this is a 10-year-old. So she was in the 5th grade. And usually if a child has dyslexia, we would hear about it earlier on. So that's in the history. So anyway, going back to the observations, the teacher reported that grade level reading skills, the parents said she enjoyed Harry Potter books. And for any of you who have seen Harry Potter, that's not easy reading. And the evaluator did not have the child read aloud. The evaluator just gave her pencil and paper tasks for reading, like read this passage and answer these questions. So the evaluator never heard her read. And then when I looked at the history was that she learned to read easily, which is not typically what we see in kids with reading disabilities, that her language skills are intact, good verbal communication skills. Again, that doesn't really fit with a reading disability. And she's never been in an IEP in the past. And most kids that we see who have a reading disability, by the time they're 10, they've already been on an IEP from the time that they were in probably kindergarten or 1st grade. So to me, all of these pieces weren't really fitting together. And I could see why the parents were questioning why she was diagnosed with dyslexia. So go ahead and turn the next page. So these were my sources of information. So I gave her some reading tests, and what I saw is that her scores were variable. Some tests she did poorly on, especially when she had to read out loud, and some tests she did quite well on. And I gave her some anxiety scales, and I had her parents and her teachers fill out symptoms of anxiety and found out that she was clinically significant for having anxiety. What I observed when I worked with her is that she had performance anxiety. And so anytime I was asking her to do something in front of me, particularly if she had to talk or demonstrate demonstrate something, she would get really anxious. And I think most of us know that when we're anxious, our performance tends to go down. I also observed that when she felt calm and comfortable with me, that she was actually a very good reader. And the history that I took was that there was a very strong family history of anxiety, and we often see anxiety running in families. She had been a really high-strung, colicky baby, and a lot of times babies who are very high-strung and cry a lot and have digestive problems are kids who are sort of wired for anxiety. They kind of come into the world genetically wired to be anxious. And the parents reported that she had dropped out of gymnastics because she was having so much performance anxiety about doing things in front of other kids. And so I took all of these sources of information and said, I don't think this child has dyslexia because the history and the observations don't fit and some of the testing doesn't fit. I think she has an anxiety disorder that impacts her ability to perform on reading tests. And that made a lot more sense to the parents. It made a lot more sense to the teachers. And we treated the anxiety disorder. What the other neuropsychologists had recommended was that she be put in a special school for kids with reading disabilities. And that would have been sort of exactly the wrong thing to do with this child. So this is just an example of how we want to weave together history, observations, and testing so that we're making the right diagnosis. Go ahead, Lauren. So when we're doing this assessment, we're trying to gather information, again, through history, observations, and testing about all of these different domains of functioning. And the reason why we're looking at all of these specific domains is because these are all of the things that can influence a child's performance in school, and school is the job of all children. And so we want to understand all of these different areas. What strengths is the child bringing to their job of learning and being in school and socializing in school, and what weaknesses are they bringing to that job? And then be able to help come up with a plan with teachers and parents so that we can help the child to function better. Go ahead, Lauren. So just briefly, because I want to make sure that we have plenty of time for Lauren's presentation. The sort of assessment process works so that we ask parents to send in any previous testing that's been done. We send out questionnaires for parents to fill out and return to us. And once we have all of that, then we meet with parents for about an hour. And since COVID, that's been happening on Zoom. And I think we'll keep it that way because parents seem to like it. And during that parent interview, we're going to try to understand what the parents' concerns are, when these issues developed, what are the demands at school, what are the demands in the family, so on and so forth. What are the parents observing? Are the parents' observations in line with the teacher's observations, and so on. And then the child comes in for usually 2 testing sessions. Some of Lauren's kids have more, but most kids school age or older will come in twice, and we'll do 5 to 6 hours of testing. And most of the tests are interactive. And so the evaluator in our center, all the evaluators are Ph.D. level neuropsychologists, not technicians. Is getting many opportunities to get to know the child, observe the child, ask questions. How did you do that one? What was hard about that? Why do you think you couldn't figure this one out? And so on. And then we do a parent feedback, again over Zoom, for about an hour and a half, where we explain everything that we determined from the testing and what our recommendations are. And then if the child's an adolescent, we'll often do a feedback with the child as well. Because one of the really most important things when kids are struggling is that they have insight and self-awareness and understanding, these are what your strengths are, but here's what's getting in the way, and here's what we can do about it. And I apologize, it's gotten so dark in here. And then the parents will get a written report after that details all of that information. I'm going to stop there. We can take that, go back to, let's stop there, and I'll take questions because I'm keeping my eye on the time.
Great. So if you do have a question, you can feel free to type it into the Q&A section. I'll also keep an eye on the chat in case anybody wants to put their question in there.
There are no questions. We can move on to Lauren and take questions at the end.
I think we can.
Okay.
Great. Just fast forward a little bit here. And there's Anne's contact information, which will be presented at the end too. So hi, everyone. I'm Lauren Halladay, as Jane had mentioned. At NESCA, I do a lot of the evaluations for kids under 5, but have seen a broad range of kids ranging in age from about 17 months all the way up until about 21 years old. So it's quite a large range. My specialty area is working with really young kids with autism and intellectual disabilities, and really enjoy working with kids who need a little bit more of a flexible approach to testing. If they're kids who don't, like sitting in a chair, like to move around a lot, make sure to always wear very stretchy pants to make sure to walk, to be able to be flexible and testing kids wherever they wander. But I'm talking to you today a little bit about the neurodevelopmental evaluation process. It echoes a lot of what Anne has already mentioned, but I'm diving a little bit deeper into some of the areas that we look at when making early diagnoses, and what are some of those early warning signs for kids who are in this age range. So again, kind of reiterating what Anne was mentioning, talking about why would a young kid need an evaluation? A lot of the times at this age, we're looking for whether they're meeting developmental milestones. So if kids are showing delays in any domain, which I'll talk about in a little bit, parents may want to talk with their pediatricians, any provider to try to get some support in figuring out what might be going on for their child. The major areas that we look at in these evaluations are communication skills. So how well kids are understanding what we're saying, how well they're able to express themselves verbally or non-verbally, their social skills, their motor skills, and their problem-solving cognitive skills. And so I'll talk about each of these areas in a little bit more detail. From a speech and language perspective, these are just some of the milestones that we're expecting kids to hit. So if the kiddos who are coming through our door are not showing any single words or not communicating using single words by about a year old, between 12 and 18 months, not using phrases by 2 years, having difficulty with following directions by age 2, and not using lengthier sentences by age 3 to communicate their needs. Those are the kinds of things that we're looking for as those red flags, like I mentioned earlier, where a speech and language evaluation or a neuropsychological evaluation may be warranted. And I have a resource here but from ASHA that kind of outlines those speech and language milestones in a little bit more detail too. From a social skills perspective, at this age, we're not necessarily expecting kids to have full-blown back and forth conversations consistently, where they're, consistently adding to what you're saying, like you maybe would with an older school-age child. But some of the social skills that we're looking for are how well kids are making eye contact, whether they're smiling in response to a parent or a familiar adult smiling. We're looking to see if kids are more interested in interacting with each other and their caregivers when compared to just objects. It's expected that kids at this age are likely going to be interested in toys. And so it's more so kind of gauging the degree to which they're interested in other kids versus objects and toys. We're also looking to see how often they are interested in getting other people's attention and drawing attention to their accomplishments, as well as getting their needs met. Maybe directing other people's attention by pointing in the distance, and coordinating that with any verbal requests of like, oh, mom or dad, look at this. Seeing if they're tracking that with eye contact too. Other things that we're looking for is how well they're using toys within their play. So the social and play skills at this age kind of go hand in hand. And so we're looking to see if there is not only interest in other kids, but how well their creativity and imaginative play skills are developing. So things like using a wooden block as a cup instead of just a cup as a cup, using that as intended. So how are those skills developing? We're looking for those to develop around 3 years of age. Now, from a motor skills perspective, it's typical that kids who are just showing difficulties with motor skills would not, necessarily just come to us if they were having difficulties with gross motor skills. It might be a better opportunity to seek out services or an evaluation, from a speech and or a physical therapist or occupational therapist. But these are also some of the milestones within a developmental questionnaire, as Anne had mentioned earlier, that we're asking questions about. So, crawling, walking, how well they're able to independently move about their environment without support. Some of the testing that we do in these early evaluations include things like fine motor skills. So how well kids are holding objects like blocks or writing utensils, if they're bringing objects to their mouth, if they're able to transfer objects from one hand to another, those types of things. From a cognitive standpoint, some of the things that we're looking at are, we're looking for object permanence, so not really searching for objects that have fallen to the ground or hidden in different locations, how well they're tracking those things, that recognizing that things don't disappear when they're out of sight. A lot of activities involve matching or completing simple puzzles. And so sometimes the delays might not be apparent until kids are a little bit older. And the testing that's done with kids who are under 5 may not exactly map on to what scores might be on testing that's conducted down the line, because as Anne was explaining with some of the cognitive testing, that those tasks become a little bit more involved and require more reasoning, abstract reasoning abilities than what some of the testing is done on some of these more developmentally geared testing. So if children are experiencing any or showing any kind of delays in these types of areas, it's not really too early to seek an evaluation. The earliest I think that I've seen in my career so far was 12 months. So that's typically the lowest age range that the testing will go down to. But, it's always good to consult with your pediatrician as well as seek out an evaluation if you are concerned about the delays in any of the developmental areas. And this can be done in several different locations. It can be sought through early intervention from kids from birth to 3 years old. And that evaluation can be done in your home. It's, typically you're not going to, early intervention providers are not, cannot provide diagnoses, and the developmental testing that they do is different than the testing that is done through our center. They're not using those, necessarily the standardized testing that we use when doing the evaluations, but can certainly help with accessing services if kids are showing those delays in any areas. The other two places that we can seek evaluations are hospital-based settings. which are usually briefer evaluations. And quite frankly, right now there's pretty long wait lists for those types of services. But they do usually have more of an interdisciplinary approach, where there's sometimes a speech language pathologist, sometimes a developmental behavioral pediatrician is on their team. So you're kind of getting access to both medical providers as well as neuropsychologists and psychologists. But the recommendations are usually a little bit more broad, and maybe not as individualized as what you would get within an independent or private evaluation through a private practice, which is what NESCA is. So we're doing these evaluations, and as Anne had mentioned earlier, really making sure to individualize our recommendations and our approach to testing to make sure that we're really understanding the learning profile of the child, making sure that we understand their strengths and weaknesses, so that we can therefore make recommendations to build upon their strengths to better support the areas that they need a little bit more support in. So this is a relatively new service that's offered at NESCA. It was something that was offered previously and has since come back, but there is a group of, I believe it's 4 clinicians at NESCA who are part of this autism spectrum disorder clinic that is geared toward getting kids in the door who are 12 months to 3 years of age, who are showing signs of autism spectrum disorder. And so we're trying to reduce the wait lists that are very apparent across hospital systems through independent practices, who are we're trying to get kids a diagnosis if it's necessary, so that they're able to access services as quickly as possible. Because as we know, there's a lot of research to support that the earlier that we intervene for kids with autism, the better the outcomes are down the line, if we're able to get them the services that are really tailored to meet their needs. So this is something that I'm a part of. It's offered in the Newton location as well as the Plainville location, and I'm more than happy to talk more about that program at the end if there's interest as well. In addition to some of the characteristics that Anne had mentioned earlier, for kids who are under 5, there's just a couple of things that I thought of to look for when selecting a clinician. So typically the questions for kids from a diagnostic perspective that I usually see in that age range are, if there are social difficulties, if my child has autism, where they are developmentally compared to other kids their age. And so typically you're looking for a clinician who has extensive experience in understanding child development, knowing what milestones they should be hitting at what ages, also having training in autism spectrum disorder, have experience working with individuals and especially young children with in that population, as the presentations are quite different depending on the child's level of functioning. But there's also times where I've had kids come in and parents contact me and they are curious about if their child has separation anxiety, which I've seen secondary to the pandemic and keeping young kids home. And so there's other things that you want to have a well-rounded clinician who also has a pretty strong background in child development. The other piece too, and it might be hard to gauge, as you are initiating the process, the evaluation process, but making sure to work with somebody who has a pretty calm and flexible approach to testing. It's unlikely it kind of like picking your battles, because it's unlikely that if I were to make a kid sit in a chair and I was only willing to have them sit and not, maybe follow them around the room or sit with them on the floor, that their engagement might wane over time. And I'm not, I want to make sure that I'm getting their best and meeting them where they're at. And that's something that I really value and think is very helpful when evaluating kids at this age. Anne already really talked about the different components of the neurodevelopmental evaluation. But similar to her description, one thing that I'm really diving into is the developmental history with these families, making sure to weigh each piece very equally. So that history piece, the observations of the child when they're in my office setting, as well as the testing data. It's possible that there are difficulties with attention and language, and maybe lack of exposure to being in more of a structured setting for kids in this age that do impact the test results. And so when that does happen, it's something that I make sure to mention within the reports, and also can help create goals around and make recommendations for down the line when parents are trying to figure out what supports are going to be best to put in place in school, or when their child is in more of a structured care setting. So I'll keep going here for sake of time, but some of the, a lot of the testing, this is kind of going back to what I was saying earlier, but when the child is in the testing room with me, I'm looking at obviously these skills within the domains that I've mentioned earlier. With speech and language, what this actually looks like is labeling different objects. A lot of the activities now are actually on the iPads, or we're using spiral stimulus books where we're flipping through the pages. Kids really like to rip the pages or kick them, which leads to trying to figure out which one comes next. But there's a lot of language testing that's done in that capacity, as well as doing a lot of observation about how they're communicating. So whether they're using sign language, if they're coming in with an augmentative or alternative communication device, those types of things. The social skills are really, we're looking at play skills, how well kids are understanding facial expressions, how well they're able to interpret and answer social questions, depending on where their language level is at. From a motor perspective, I'm asking them to do things like manipulating different objects. They might be putting pegs in a pegboard. They might be putting coins in a really small slot. And from a cognitive perspective, a lot of it is puzzles, matching, sorting objects by color, by shape, by size, those types of things. So after all of that data is collected, as both Anne and I have talked about, this really, the purpose of the neuropsych evaluation and what comes as a result of the evaluation is really a better understanding of the child's learning and developmental profiles. And so it can help, especially at this age, whether the child is having is delayed in any areas or is more advanced. And it may result in a diagnosis, but also can, even if it doesn't, we can say there's a pattern of strengths and weaknesses here that we can use to make recommendations, so that we can also, for supports that could be in place in early intervention, outside of early intervention in school, as they get older. So it's really about really just understanding the profile of the child and what they need in order to be successful. I think that's all I have.
Great. So we do have a few questions. I think these could be for either one of you. My daughter is bright and very good at masking. We did a neuropsych eval and she was diagnosed with anxiety. She might be autistic, but because she does mask, it's not obvious even to me. I'm curious about your experience with very bright girls, possibly on the spectrum.
Lauren, do you want to take that one?
Sure, I can certainly start. A lot of my experience with individuals on the spectrum has been primarily young children, and mostly males. But you know, some of the things that I've noticed in working with girls, the few that I have worked with, is that a lot of that anxiety, a lot of girls tend to have more of that social motivation and interest in their peers. And so there tends to be more of a social comparison aspect, which can then cause anxiety, especially if they're masking some of their symptoms. If they're like, I'm not sure if I should be acting in this way, but it's maybe my more natural inclination to act in that way. But my peers aren't acting in the way that I would. So I think that the differences in that social comparison piece can lead to some of to be feeling a little bit more anxious. But Anne, I'm not really sure if there's anything else that if you've had experience in this area too.
So I guess one thing that I would wonder is what instruments were used in the neuropsych evaluation. I think sometimes what we see is that evaluators over rely on observations and they say, oh, she was great, she was social, we talked, she must not have autism. And some of those kids, when we give them the ADOS, which is a detailed battery for kids with autism, or we really go very carefully through, there's another instrument called the CARS that allows you to go sort of symptom by symptom, we find out that actually they do meet criteria for autism, but as this parent is saying, they're able to mask it well. And so I think it's really important to have an evaluator who uses all of those tools to help with the evaluation.
Okay, and then what are your thoughts about the results of a remote neuropsych evaluation?
I guess we can both speak to that. So when the pandemic hit, NESCA decided that we were not going to do computer-based testing. We were not going to do remote testing. And so what we did was to have plexiglass panels put in the shared wall between two offices, and then got headsets. And so the evaluator was in one office, the child was in the other office. That way nobody had to wear masks. We weren't worried about COVID. And we did that because I felt really strongly that we needed to see the child, interact with the child, and keep everybody safe. That being said, the research, what little has been done since the pandemic, suggests that the remote testing is accurate for most kids, probably less so with the younger kids that Lauren is testing. But there's not any compelling research that says that it's not good. For me, I just would far rather have the face-to-face contact without masks.
I would second what Anne says. I think when the pandemic hit, I was working in a hospital setting, and a lot of the autism specific testing switched over to a remote platform. And we actually tried to instruct parents on doing some of the tasks that mimic some of the tasks that are done using an ADOS, which is the measure that Anne had mentioned earlier, which is that play-based measure. And so it was quite challenging to direct parents to do the skills that we, I guess, follow the instructions that we were asking them to do while also managing their child's behavior, because it's a hard expectation to set when they're not trained in doing those types of things. And so especially when your child is not going to stay in front of the camera. So I think it depends on the presentation too. But I would much rather see the child in person than over the camera.
And how often should we go for a neuropsych evaluation for a child with autism spectrum disorder? My daughter is 6 years old, and when would we go in for IQ testing?
Usually IQ testing is part of the initial autism evaluation. So typically the pieces are an intellectual assessment, autism specific testing, as well as questionnaires and collecting information about developmental history. Typically what I recommend is every 2 to 3 years, but it really does depend on the learning profile and what the child is at risk for. If they're at risk for learning disabilities, if they're showing, in their initial evaluation, showing difficulties with reading, monitoring those types of things, you might seek an evaluation sooner. But it kind of depends on the profile.
Yeah, I would just add to that a lot of times with the families that I work with, we have the child come back for sort of targeted testing. So like, for example, the case study that I presented here with the girl with an anxiety disorder, I gave the parents recommendations for a therapist. She ultimately ended up seeing a psychiatrist, and then she came back a year later so that we just evaluated what was happening with anxiety, because that's what we had been treating, and wanted to see if things were on the right track. And it gave me a chance to catch up with how things were going in school, and help her get ready for her transition to middle school and all that. So it really depends on the case.
Hey, my 3-year-old boy has good eye contact, language, and motor skills, but does not play with other kids at daycare, and some of the times gets overwhelmed in a big classroom. I have an older son who does have autism, and wanted to know if the younger one is also on the spectrum. What would be your recommendation there?
So there's a high co-occurrence between siblings with autism. There's a higher risk factor if you have one child who has autism with the sibling. So if you're seeing signs that you're concerned about or delays in any area, I would recommend seeking out an evaluation.
And then, is there an age range when IDD is diagnosed?
To clarify, IDD, do you mean an intellectual disability?
Yep.
Yes. Okay. So typically I don't make a diagnosis of an intellectual disability until after 5 years old. Typically it's called a global developmental delay prior to that, but just because a child has a global developmental delay doesn't always necessarily mean that that'll go and turn into or be called an intellectual disability, but usually the age is about 5.
Okay. And what is the wait time for a neuropsychological evaluation for a 10-year-old at NESCA?
At this point, we have openings in November, and we may even have a cancellation or 2 in October. So we have, I think, 12 doctors at this point. So we're able to get people in relatively soon.
And once we have the report, what are the recommended next steps as far as school or the recommendations that are provided within the report? Does NESCA help with those?
That's a great question. So that's something that should be discussed at the feedback. So the neuropsychologist should explain at the feedback what the next steps are for this family. So in some cases, it might be, we need to reach out to your school and have an eligibility meeting to find out if your child is eligible for special ed services, and here's how we can support you in that. Or we might say, given the results of this testing, we don't think that the program that the school is providing right now for your child is appropriate. And so the next step would be for us to go observe the program so that then we can comment on that. So it really depends on what we find in the testing. But one of the things that NESCA prides ourselves on is helping parents through whatever needs to be done to get the recommendations implemented for their child. So sometimes that means doing a school observation. Sometimes it means attending a team meeting. In rare cases, it means testifying at a special ed hearing. So we really stand behind our reports and stand behind the families that we're working with, and we want to make sure that that the recommendations get implemented. We will also help you to find resources that you need. So if you need a cognitive behavioral therapist for your child, we'll reach out among all of us in the practice and say, hey, does anybody know a cognitive behavioral therapist in Marshfield? So that we're getting personal recommendations from our colleagues here for families. And many of our families we build relationships with over the course of the child's lifetime. And that's really helpful because then we're seeing the child at different points. And so we start building this sort of picture on our mind of what the trajectory of their development has been, what sorts of things they've responded to, what have they not responded to. We have a nice trusting relationship with the parents, with the child. And so that longevity is really important too.
Great. And does NESCA do out-of-state evaluations, and does it accept insurance?
We do out-of-state evaluations if the out-of-state person comes to us. There are strict rules as a psychologist that we're all licensed in Massachusetts, and so we're not allowed to travel to New York and do an evaluation in New York. Somebody from New York can come to Massachusetts and be evaluated there. A few of our clinicians are licensed in New Hampshire. I don't think there's any other state that people are licensed in. We do quite a lot of international work at NESCA, and these laws do not apply to international work because, for example, I've done a lot of work in the Philippines and a lot of work in India, and those countries do not have laws saying that if you're licensed in Massachusetts, you cannot practice in India or the Philippines. And so I have done remote testing with people in those countries. And in terms of insurance, I would say the majority of the clinicians at NESCA accept Blue Cross Blue Shield.
Actually, building on that, Anne, do you want to talk a little bit about the difference between the academic testing and the
Sure. So Blue Cross Blue Shield will only cover what they consider to be medically necessary in the neuropsych evaluation. And so what that means is that they will cover sort of the administration of specific tests that look at communication, IQ, and so on, but they do not cover academic testing. They also don't cover things like us reading the child's IEP, working with the family on what the next steps are educationally, looking back through all of the educational history, all of that. And so there's a separate fee at NESCA that covers all of the, not only the educational testing, but the integration of the educational testing with everything else and the educational planning that we end up doing quite a lot of with families. And at some practices, you can choose whether you want neuropsych testing or ed testing, or you want the combination. At NESCA, we only do the combination because my feeling about that is that, as I said earlier, kids' job is school. And so we need to understand, you know, that's their world. That's where they spend 6+ hours a day away from you. That's where their social development's happening. That's where their academic development is happening. We need to, we need to understand how they're doing at school and how to help them do better at school, regardless. So it's not a choice at NESCA. It's always integrating.
Here's one more. My kid is 6 years old and is on the spectrum. He regressed a lot in terms of speech and academically is very behind from his peers after starting kindergarten and also elementary school. What are your further recommendations?
Lauren, do you have any thoughts?
I think I'd be curious what the school services are that have been in place for your child, to see if there's any adjustments that need to be made to school programming, as well as the data that's been collected through school, or in different neuropsychological evaluations over the course of your child's life so far. It may be helpful, to seek out that type of evaluation or to collect more progress monitoring data to see how we can, make adjustments to the services that are being provided at school from an academic perspective.
Right. And where are your offices located?
Newton is the main office. We also have an office in Plainville, which is by Foxborough. And we have recently opened an office in Hingham, or we're about to open an office in Hingham in November, and in Londonderry, New Hampshire.
Excellent. I think those are the questions as of now. We'll keep this up for just another minute or so, but please always feel free to reach out to me. I can certainly direct any other follow-on questions to either Lauren or Anne. And we can also provide the presentation to you, the slides from the presentation, just as a follow-up. And I think that's it. I don't see any others coming in. So thank you, Lauren and Anne, for your time. And thank you, everyone in the audience for joining us this evening. One other question. What is the ballpark pricing?
For children, Lauren, help me out, children over the age of 4, is that right?
I think it's 4.
Children over the age of 4 is $5,500 and children under the age of 4 is $3,200.
Yep, here's another one too. My child has a neuropsychological evaluation, but the school is denying to offer services. What do I need to do? A familiar story.
Absolutely. I would first see if the neuropsychologist can come to a team meeting with you to figure out why the school is refusing, and then they should be able to advise you on next steps, which sometimes involves getting an educational advocate or an attorney. But I wouldn't just take no for an answer.
All right, so that concludes our presentation for the evening. Thank you again for joining us. And again, we will be sending the slides, and feel free to respond to that email with any additional questions, and I can be sure that Anne and Lauren receive those. Thank you so much and have a good night.
Thank you, Jane.
Thank
Bye,
you.
everyone.
Bye. Take care.